In the state of Missouri, we have the highest rate of mortality from heroin and fentanyl and other opioids. In addition, large segments of our population in this area also don't have the resources that are available to others.
You definitely need some physician champions that have bought in to treating opioid use disorder. You need to have your nurses engaged within the hospital system. You need to have your pharmacists engaged. And then you do need strong community linkages.
Somebody offering me a little bit of help was really all I needed to light that spark of hope.
The first steps in starting a program like this is to really look at what resources you have in the community to help you with all this. Trying to tackle all this by yourself is going to be very, very difficult.
Our job is to facilitate the patient meeting with the recovery coach and facilitate their aftercare plans. And we also coordinate communication between the recovery coach and the doctors and the treatment team in the emergency department.
EPIC standing for Engaging Patients in Care Coordination. This was Behavioral Health Network's idea to give recovery coaches the ability to come into the hospital and give a patient access to medication-assisted treatment as well as substance use treatment within 24 hours. They were the first hospital that was partnered with EPIC. They've done a great job from top to bottom of making this thing work.
The recovery coaches can help with the logistics that might have been barriers before. Then we just go from there, make sure the patient's agreeable to the plan.
We really don't discriminate between heroin abusers or patients that use illegal opioids versus the patients that are using legal opioids.
Once you get these patients into treatment, it's really a light and day difference. You really get to see the effect of the treatment and everything on them and how they've turned around their lives, and so that aspect's really rewarding.
Since we began the project, Barnes-Jewish Emergency Department, we've referred in over 1,000 patients.
It clearly addresses treating patients with opioid use disorders, and then for those patients that don't have opioid use disorders, it hopefully prevents them from being exposed to something that could cause them to have an opioid use disorder.
Before, they were just leaving with no medication with the hope they would follow up and eventually get it.
Hopefully, as this continues to progress, it'll just become another treatment just like treating any other chronic disease. And it allows us to continue treating it out of all sorts of different settings, whether that's in the emergency department, the hospital ward, or out of a primary care office.
It was a lot more of a warm handoff to treatment than the pamphlets I had been given before and the physicians who told me, "You're a heroin addict, you need to get help." And then that ended there.